Good afternoon, everyone. I'm Leslie Kumler, Marketing Coordinator here at VisualDx, and I'm pleased to introduce our two presenters today. We have Dr. Jeff Bazarian, who's a professor of emergency medicine and neurology at the University of Rochester. He runs an active concussion clinic and research program at the U of R. He's served on a number of traumatic brain injury-related task forces and panels, including the CDC, the National Institutes of Health, the National Science Foundation, and the Institute of Medicine. And we also have Pam Mapstone, who's a pediatric nurse practitioner at the University of Rochester and an associate professor at the Wegman School of Nursing at St. John Fisher College. She's practiced in primary care, child neurology, pediatric emergency, and now works with Dr. Bazarian and the pediatric concussion program at the University of Rochester. So I'm going to turn it over to our two speakers.
Thanks, Leslie. This is a lot of fun to be talking to you all through VisualDx. And Pam Mapstone and I are going to spend a few minutes talking about how we manage sports-related concussions in children and adolescents. And we're looking forward to your questions as we kind of go through some of these slides. All right, so let's start off with a case, which would be the next slide. Okay, so this is kind of a typical adolescent concussion patient that Pam and I thought would be perfect as a springboard for the rest of this talk. So we evaluated a 14-year-old male. He had a history of ADD, as many of our concussed athletes do, for which he was managed on Adderall, 30 a day, but no prior history of concussions. And this 14-year-old was playing football, got tackled, head hit the turf, even though he was wearing a helmet. He didn't lose consciousness or have amnesia, but he felt confused, which kind of got him into the we think he's got a concussion category. Because of his confusion, he was transported to the emergency department at the University of Rochester, where he had a head CT that was normal. He also had an X-ray of his cervical spine, which was negative as well. And we saw him in the clinic about 6 days later. So when we saw him in the clinic, the first thing we do is kind of get a handle on the breadth of his post-concussive symptoms, and we use a structured symptom checklist that's actually part of a computerized cognitive test that we give, but it's a useful way for us to get in a structured kind of way exactly what the breadth of the symptoms are. And so there's a way to kind of not only know what symptoms he had, but the severity of them. And this table, you can see the severity ranges from 0 to 6, so you get a total score. And 85 is pretty high. So 6 days later, he's pretty symptomatic. And when you kind of cull through all those symptoms, his main problems were over here on the right. He had a lot of daytime fatigue. He was very tired during the day. He had a migrainous headache. We'll talk about that in a minute. And he had a lot of dizziness with head movement. So those were the three problems that we focused on. On physical exam, and you'll hopefully get a flavor for the kind of physical exam we need to do on a concussed athlete. It's kind of like a neurologic exam, kind of, but not entirely. So it's focused. So the physical exam for him is kind of the typical exam we do on most concussed patients. Head and neck exam, normal. There was no evidence of trauma 6 days later. But a neurologic exam, there are several things that were not normal. His motor strength was fine. Cranial nerves were okay. Cerebellar testing, to the extent that we do it, we don't do extensive testing, was normal. He had no nystagmus, his gait was fine. He had his finger to nose and heel to shin were fine. But here's where the abnormalities typically lie in concussed athletes is with an assessment of their vestibular function and their cognition. So the vestibular system is commonly injured. His was injured as well. He was very wobbly when we did a Romberg. We stood him up and closed his eyes and had him put his arms out. He was wobbling, which is not normal. And when we tested his eye movements, he was dizzy with both horizontal and vertical vestibular ocular reflex testing, as well as with something called VOR cancellation, and we'll describe that in a moment. So those are abnormal. His near vision function was also abnormal. His near point convergence was 10 centimeters, should be 6 or less, so that's abnormal. And his accommodation in each eye was abnormal. It should be less than 16 centimeters. His was 20 on the left, 23 on the right. So not normal. In terms of his cognition, which is essentially attention and memory, we use a computerized test. On the right, you can see the results are the raw scores, and if you see where it says composite scores, you'll see 4 raw scores, and over on the right there are these percentages. That's how he compares to boys his age. So it says less than 1%, less than 1%, less than 1%, 2%. Anything less than 10% is considered impaired. So he was impaired on all aspects of cognition, which is also pretty typical for someone with a concussion. So our assessment with him was that he had a migrainous type of post-traumatic headache. We put him on amitriptyline. We started at 12.5, went to 25 milligrams. He had some insomnia and fatigue. His fatigue was probably related in part to his concussion, in part to his history of ADD. So we increased his Adderall from 30 to 40 milligrams a day, which also actually helps, or ostensibly helps, with the cognitive deficits. For the vestibular issues, we sent him for vestibular rehab by our physical therapists. For the problems that he had with near-point accommodation and convergence, we sent him for vision therapy, also by our physical therapists. And one of the things that we do kind of in general is we tell him to hold on contact sports and PE. We don't want him hitting his head during this period of recovery. And we put him in our return to learn zone 2, which I'll tell you about in a minute. But we told him to do some daily light aerobic exercise, since we know that's helpful. And sure enough, 3 weeks later, he was better. All of his symptoms were resolved. He was off the amitriptyline. His Adderall was back to its normal 30 milligrams. He was cleared to return to play, and he was back to full academic functioning. Okay, so that's the case that kind of hopefully will get us thinking about how we care for folks with concussion. Now, I was going to spend the next few slides, if you wouldn't mind, the next slide, kind of going to this in a little more detail. And I really would like Pam to jump in here. So first of all, what exactly is a concussion? What gets people into this category? I mean, the technical definition is there needs to be some mechanism of trauma, like a blow to the head or some rapid deceleration with one of these things, some brief loss of consciousness, a brief period of amnesia, or a brief change in mental state, like confusion. But the patient has to look awake and alert. So essentially their GCS needs to be normal, 30 or more minutes after injury. So we're not talking about someone who's in a coma. Now this definition is kind of in flux, and it often will include other symptoms like headache. We get many patients referred to us who have just headache. They don't have any of these other things. They just have headache, and boy, they clearly are concussed. Everything we do on them is abnormal. So the definition is starting to morph as we know a little bit more about this injury. One of the important things to understand is that concussion is not a single entity. It involves disruption of multiple brain functional domains. And these are the things that we're evaluating on each patient that comes to our clinic. So the domains that go out of whack are, for example, insomnia, which is sleep regulation, memory and attention, mood regulation, headache, which is actually a symptom of pain regulation. So there's a problem with dysregulation of pain. Near vision function is not right. Autonomic dysfunction, regulation of blood pressure and heart rate isn't normal, and vestibular dysfunction. So there's a lot of things that go askew, and we're evaluating all of these. All of these problems that people have after concussion are often associated with risk factors. So for example, someone who has a history of insomnia is more likely to have problems with sleep after concussion. Someone with a history of migraine headache, a personal or a family history, is more likely to have a migrainous headache after concussion. So this figure, all those red circles that are down to the black ones are the risk factors for each of the kind of the functional problems that we see after a concussion. So it's important for us to get a gauge on these risk factors when we're evaluating patients, so that we can expect or anticipate that they might develop a problem if they don't have one. The middle figure, the brain in the middle, is to remind everybody that this is essentially a midbrain injury. We can find neurons scattered all throughout the white matter of both hemispheres, but the main problem are the white matter tracts in the midbrain. And most of these functional domains are controlled by structures in the midbrain. So this is kind of like a midbrain injury. It's probably the best way to think about it. And the overarching concept is that this injury to the midbrain, these functional domain problems translate to the symptoms that we commonly see among patients in the clinic. The somatic symptoms like headache and neck pain, the cognitive symptoms, problems with memory and attention, as well as the emotional symptoms, irritability, anxiety, etc. Did you want to add anything to that, Pam?
No, you're on a roll.
All right. So everyone always says, how long does it take for people with concussion to get better? And that's a great question. It's quite varied. And the old thinking used to be was like a couple days. It's more like a month. I think a month is probably a reasonable number to have in your mind for a typical concussion recovery. Athletes tend to recover the quickest because they're very motivated to get back to their sport. It doesn't necessarily mean that their brains are recovered. Here is a graph that we have from athletes at the University of Rochester, and their recovery trajectories kind of divided up by the clinical symptoms like headache, vestibular dysfunction, cognitive, sleep, anxiety, mood, and their eye function. And you can see everybody has got 78 people. Everyone's got a lot of symptoms in the first 5 days, and they kind of gradually resolve over time. But it takes time. It's not something that goes away in 2 or 3 days. And really, we have people kind of percolating out to 40 days that still have symptoms. But as you can see, overall, by like 20 days, 20, 25 days, people are getting back to baseline. But the point is, it's not a 2 or 3 day thing. It really is, more like 3 to 4 weeks. And here's an example of one patient that Pam and I took care of. And this patient had problems that went out for a long time, but the clinic visits really seemed to help. So all of these lines are the degree of symptoms this person was having: headache, vestibular, cognitive. The first vertical arrow is when we first saw this person. It was a 20-year-old female in the clinic, treated her, and a lot of her symptoms got better. We think it might be from the treatments, we hope. It could be just from reassurance, who knows? But they kind of plateaued. You could see they plateaued over the ensuing days, and we had to adjust some of our treatments when we saw her again, and then the symptoms finally resolved. So this is kind of a dynamic process, and we often need to do some tweaking with patients as they come in. Some symptoms crop to the top that were buried early on. You can see, for example, the brown, which is vision problem for this particular patient, was not particularly prominent early on, but became a problem later on. So, we kind of, these subsequent evaluations are really critical for us to get the symptoms gone and the patient recovered.
Can I just add something to that as well? I think it's really important to not just say every kid is going to recover in 4 weeks, therefore we're taking him out of school for 4 weeks, we're taking him out of sports for 4 weeks. Every kid is very different and depends on what issues they come to the concussion with. If they have pre-existing anxiety, if they have pre-existing depression, pre-existing history of migraines, they're at risk for taking longer to recover. And so in primary care, it should be something where these patients should be seen. If they're not being seen at a clinic like ours in primary care, they should be seen every week to evaluate progress. They always need to be moving forward. Things need to be getting better. They should not wait 4 weeks to find out that things aren't better and then send them to us. So if they're not getting better, if they're not making progress, it could be the wrong medication for the headache. It could be school anxiety. It could be a lot of other factors that need to be addressed before they will get better. So either refer or see them more frequently.
That's great, thanks, Pam. So I want to spend the next few slides talking about how we kind of evaluate patients. It's very much symptom-based, so we take that structured symptom checklist that I showed you at the beginning, and we start to plunk through it. So if someone has problems with memory and attention and concentration, we perform cognitive testing. There's several ways to do this. There's an expensive way and a cheap way. Of course, we're with a big university, so we chose the expensive way, which is to do computerized cognitive testing. And we get kind of objective measures of attention, recall, and reaction time. But you can also do it pen and paper. And the child scat, which is over here on the right, you can download that for free. And it's like a pen and paper thing. The reason why we like the computerized cognitive test in our area of the country, in the Rochester area, most high school and collegiate athletes have a measure of attention on this particular system at baseline before they're injured. So when they get injured, we have something to compare them to, their own personal baseline, which is super helpful for us to determine recovery, and would have been super helpful in the patient that I mentioned to you, because someone with ADD is not going to perform like someone without ADD on a test of attention and memory. Having their personal baseline would have been much more convenient than kind of comparing them to a database of people that don't have ADD. So when we have that, it's super helpful in our management. All right, so how do we evaluate complaints of dizziness, fogginess, and off balance? So this gets at the vestibular testing, and this is probably the core of our exam. And it's not very difficult to do. We use a structured tool called the VOMS, which is the Vestibular Ocular Motor Screen. It was developed at the University of Pittsburgh. But essentially, it involves doing these 4 maneuvers. Smooth pursuits, we're literally just holding a finger or pen in front of the patient and having them move their eyes horizontally and vertically. And we're looking to see whether the eye movements are normal, but we're also looking to see whether we're provoking symptoms like nausea, dizziness, or headache. So that's often a key, that the vestibular system is abnormal, that we're provoking symptoms, not so much that we're seeing abnormal pursuits or seeing abnormal saccades, but that these maneuvers are provoking symptoms. So for saccades, we hold 2 fingers up, 3 feet apart, and ask people to just shift their eyes back and forth really quickly, and we do it up and down as well. The VOR, gaze stability, this is actually just have them hold their arm out with their thumb up. We tell them to keep their eyes on their thumb, but to move their head back and forth. And then we have them do that horizontally and vertically. VOR cancellation, which is really more of a cerebellar thing. They're standing up in a room with something on a wall that kind of would be a distractor. We're telling them to keep their eyes on their thumb and turn their whole head and body 90 degrees left, 90 degrees right, swing back and forth while they're keeping their eyes on their thumb. People who have vestibular dysfunction can't do that. They can't maintain fixation on their thumb when they're doing that, or they get super dizzy. So this is the primary way that we're kind of figuring out whether they have a vestibular issue. So this is now the vestibular ocular part of the vestibular system. There's another half to the vestibular system, the vestibular spinal, which controls posture and gait, which I'm pretty sure is the next slide. And some of you may have heard of doing balance testing, and the best test, the balance error scoring system, is probably the most commonly used test. This is actually fairly low yield. Most people can maintain postural stability, but still have a vestibular issue. So we do more of the stuff on the previous slide than this, but I wanted to show you this for completeness' sake, because this is a commonly done test. You can do it with or without a foam pad. The idea is you're having your athletes stand in 3 different positions for 20 seconds with their eyes closed, and if they move or lift a hand up, they get a point, which is like an error point, and you add up the points. So you do 3 stances on firm ground, and then 3 stances on a foam pad. Many people just do the first 3 stances on the ground and don't do the foam pad because it's a pain. So the foam definitely makes it harder, and you're more likely to tease out vestibular problems. Our issue with this particular test is that it's definitely confounded by extremity injuries. If you have an ankle or a knee problem, you're not going to be able to do this, and your degree of physical fitness. People who have really good core strength are really good at this. So it almost makes it hard for us to know whether they have a vestibular issue if they have really good core strength. So it's a tough test to work with, but it's a standard one, which is why I wanted to include it. Mm-hmm. All right, so here's how we evaluate symptoms related to vision. So people will often say, well, my vision's blurred, it's double. So here's where we're looking at what we call near vision function. Some people call it oculomotor testing, but really it's near vision function. We're looking at 2 aspects of near vision function. And these are the things that go out of whack after concussion, not acuity. Acuity is not a problem. Dynamic acuity is, so being able to focus on something when it's moving around is a problem because that's a vestibular issue. But these are the two near point functions we look at. Near point convergence, which is basically like how close can you see the tip of a pen coming up at you towards your nose before it turns double. And you can kind of, play with this yourself with both eyes. And most people should be able to get within 6 centimeters or so of their nose. If they're more than 6 centimeters, if they're seeing double more than 6 centimeters out, that's a problem. That's considered convergence insufficiency, which is a common issue. It's not an eye problem, it's a brain problem. It's the brain not telling the eyes how to come together. The same thing for accommodation. We do this, obviously one eye at a time, and we just ask people to look at some letters on the tip of a tongue blade. And, we want to know when those letters are blurry as they move that tongue blade towards their face. And if they can get within, 16 centimeters or less, that's good. If it's outside of 16 centimeters, that's considered abnormal. And we do that for each eye. So again, this is nervous control of the eye function, the eye apparatus that controls accommodation, which is the ciliary apparatus and stretching that lens, to make it flatten out so you can see something coming at you. It's not an eye problem per se, but both of these are typically abnormal after concussion.
A common complaint you might hear from kids who have this is that they're fine without a headache until they start going back to school, and when they go back to school, they get the headache. And then when you ask more about when they get a headache, it's mostly when they're looking up at the board and then looking back down at their paper and then looking up, so that their eyes are having to kind of adjust to small letters on the paper and then look up at a distance, and the eyes are just not working together, and they'll get headaches just from that type of eye movement.
Right, so that's a great point, because that's a headache from an eye problem that if we don't fix it, they're going to continue to have a headache. So all the headache medicine in the world isn't going to fix that problem. So neck is also very important to evaluate. The neck has got a set of nerves that actually feed into the vestibular apparatus and kind of tell the brain where the head is in space. If the muscles of the neck are tweaked, the signals coming from those nerves going to the vestibular apparatus are kind of imbalanced. So the eyes will say the head's pointed one way, but these proprioceptive nerves in the brain, in the neck, say the head's pointed another way, which usually is what results in the sensation of dizziness when the brain gets kind of discordant information. So evaluating the neck is super key. Neck muscle strain also contributes to headache. So if there's a neck muscle issue, we want to take care of it. So the exam is pretty simple. We do range of motion and we do palpation. It's really nothing more than that. And evaluation of headache. So this gets a little tricky. You kind of have to ferret out the headache a little bit. So we try to figure out what kind of headache bucket, what the phenotype of the headache is. Is it more migrainous? Is it more tension type? Is it more cervicogenic? And most of the post-traumatic headaches are migrainous, but not all. Sometimes there's a mixed bag. But it's really important if they have a migrainous headache to identify that, because it's pretty treatable. And the key for migrainous headache is that it's they're sensitive to light and noise, which means they're photophobic and or phonophobic, and they have some nausea associated with it. So like if we get a flavor that it has those migrainous features, then we'll start to think about treating it that way. Cervicogenic headache doesn't have those issues. It really is more positional neck stuff, headache first thing in the morning after sleeping on a pillow. Often cervicogenic headaches go away pretty readily with non-steroidals or Tylenol. Migrainous headache does not. So you can get some clues for what headache bucket your patient is in just by asking a few of these questions. So mood issues after concussion are huge, and we're realizing this is often the problem that will get a patient stuck at a certain point of recovery. So anxiety, depression, irritability are super common after concussions. A lot of it has to do just with the athlete being pulled out of their normal activities. Anybody would get anxious or depressed if they weren't able to do the thing that they love to do the most. But some of it is from the brain injury itself. So it's important for us to try to tease that apart, figure out what their sleep history is like. Sleep is so key for many aspects of life, including mood, and concussion disrupts sleep. We also try to ferret out if they're using substances. Pam is really, really good at this. Usually you have to kick the parents out of the room and find out if they're smoking pot, because, you know, a lot of adolescents are, which might help with their sleep. It probably won't help with their mood. And then trying to pull apart whether there's pressure from families to stay in the sport, which is often causes a lot of stress for kids, or whether there's some other psych problem in the background that just is popping up now with this injury.
So back to the case study of the kid that we presented, I saw him multiple times in his recovery, and although it made it look very straightforward, oh yeah, we put him on amitriptyline, you know, I can tell you that it was not that straightforward. We had to increase his dose of amitriptyline. We actually took him off of amitriptyline and put him on a different medication because he wasn't sleeping. And when kids tell me that they're having trouble falling asleep and their thoughts are racing, anxiety kind of pops into my head. And when I first asked this kid, you know, what are you anxious about? Nothing. So then I went at it from a different angle and I said, let's talk about school. Tell me what assignments you're worried about. And we went through every single class. And after that, you realize that all this kid was thinking about was all of the assignments that he was missing and how he was going to make them up. And once we came up with a plan of how that was going to happen, he recovered a lot quicker. The other thing was he was really trying to get to finish a hockey tournament, and once we kind of worked through how that could impair his golf season, which is what he really wanted, we negotiated, and I said, you give me this hockey tournament that you don't play in, and I'll probably give you your whole golf season. If you go into this hockey game and you get hurt again, you're probably out for the rest of your golf season. Even though golf's not contact, trust me, we've seen concussions from golfers. So really, if kids are not getting better, it is so important to really look at anxiety and depression as things that may have crept into the picture and might be kind of holding them back from recovery.
Right, I think thanks to Pam's intuition here, we started screening everybody for anxiety when they come in, and we found a bunch of people that have anxiety, and it's good for us to know up front.
Very helpful.
And we tell them this could be an issue, but that's okay. We know about it, and let's just see how things go. I think Pam is 100%, and I really want to make a plug for Pam. Like I feel like to take care of concussion patients, it really takes more than one person. I can't see one person having all these skill sets to handle the problems that go wrong, and I feel really thankful to have Pam working with me to help. And so, you're welcome.
Thank you. Not necessary, but it's definitely, if you work in a practice and you're trying to manage this by yourself, it is overwhelming. So if you can partner with somebody else in your practice and work together, it's much easier.
One of the general recommendations we give, everybody wants to know about rest, right? So in the old days, there used to be this thing called cocoon therapy, where you keep someone in a dark room, until they were better. Turns out that's not the quickest way to get someone recovered. The best way to get someone recovered is to make them rest for a day or two, and then to get them going. Just like everything else in medicine, I remember low back pain. We used to put people in bed for days and weeks. Not anymore. Cardiac surgery, we used to keep people in the hospital for days and weeks. Not anymore. So same thing for brain injury. You have a brief period of cognitive rest, physical rest, maybe like a couple of days, like 1 or 2. And then we start having people do more. We want them to get out, start moving around, start challenging themselves cognitively as well as physically. So this is a kind of a new thing, to get people moving pretty soon after the injury. And there's a group in Buffalo that has shown that the sooner you get people exercising, the better. I think that helps from a brain recovery standpoint as well as from a mood standpoint.
Especially in adolescents.
Especially in athletes, to say, you're an athlete, let's go. They love that. They love to hear that you're telling them to do something. So part of what we do, obviously, is to educate patients on what to expect after concussion. And, the fancy term for that, this is now called cognitive restructuring. but it's just basically education, like telling them that what they've got is totally expected after concussion and that they're going to get better. So this reassurance is super helpful to tell them that you are going to recover, because some of them think I'm never going to get better. And when you plant that thought in their brain that they are going to get better, it really helps them move forward. We also work with them to make sure that they're attributing their symptoms to the injury. Sometimes people like to say, I just haven't been the same since this concussion. And when we start to pull that dialogue apart, we found, well, I think you haven't been the same since your grandmother died 2 years ago. I think that's really what, so we want to make sure that they're not attributing everything that's wrong in their life at the time to this injury, which is a very kind of natural instinct, but we kind of need to resist that, because then it makes it harder to do the first two things, the education and the reassurance.
We see this all the time. We have a lot of providers who will attribute, they'll have a patient come in, they'll see that they've seen us for a concussion, the kid will come in for something and they'll just attribute it to the concussion and send them right to us, and maybe the kid just has the flu. The kid's headache was gone, but now the headache's back and they're dizzy and they're breaking out in sweat, and they want to say, oh, send them back to the concussion clinic. Well, how about maybe it's flu season and it's just the flu? Or we've seen adolescent girls with nausea who actually were pregnant, and they kept getting sent back to us for the nausea after a concussion, and guess what? They're pregnant. So you have to really be sure to kind of tease out those symptoms.
Okay, so now let me shift away from assessment of these things to what we do about them. So if we find a problem with neck pain, that's pretty straightforward. We can recommend the typical over-the-counter analgesics, heat and cold, but physical therapy is really what gets this better. Physical therapy essentially involves stretching and strengthening. So this is different than chiropractic manipulation, which is not about that, or even, massage therapy, which is not about that. So there's a lot of evidence that stretching and strengthening is effective for neck pain in this setting. There's lots of other things you can do with the neck, but it's that modality for which there is the most evidence. So patients will say, what about acupuncture? Okay, sure. Probably not going to hurt, but it isn't going to work as well as this stretching and strengthening, which is totally in the wheelhouse of most physical therapists. Okay, so what do we do for headache? So there's a couple things we do. We do subthreshold exercise, but I already told you that we kind of get patients moving as quickly as we can. We want them doing 20 to 30 minutes of something aerobic every day, even if it's just walking, exercise bike, treadmill. If they have any degree of vestibular dysfunction, which means if they move their head around, they feel bad, then we'll recommend they not do running, but maybe more exercise bike, something where they're not moving their head around, exercise bike or even elliptical. So, but we really want them moving 20 to 30 minutes. Doesn't have to be fast, doesn't have to be hard. It just has to be every day. And the group in Buffalo, right down the road from us, John Letty's excellent research group, showed that this actually speeds recovery after a concussion. So there's some pretty good evidence base that this is helpful. We do rely quite a bit on medications for migrainous headache. And I think the one we use the most frequently is amitriptyline. This is a slide from a researcher in Canada who showed us the frequency of the medications she uses in her pediatric concussion clinic. So she uses a lot of amitriptyline as well as melatonin. We start with amitriptyline generally because it's a great migraine medication. It's well tolerated. It's easy to dose. And its biggest side effect, which is sedation, is super helpful in people who have concussion, because most of the time their sleep is disrupted. And the side effect of this medicine actually improves their sleep architecture. So you're killing two birds with one stone. It's helping headache and it's helping sleep. The side effects are tolerable: dry mouth, constipation. That's pretty much it. We tell patients not to get pregnant while they're on this. And this is our go-to. When this one doesn't work, we used to go to topiramate. Now we're doing more zonisamide, which is another migraine medication. Occasionally we use melatonin, which not only is a sleep aid, but has some headache properties as well, or anti-headache properties as well. If you want to see evidence-based for these treatment recommendations, these are two nice documents that you can download off the internet. You can't download them from this slide presentation, but you can see the evidence base for these meds in these two documents. When people have trouble with memory and attention, we have a couple of options. One is to do cognitive rehabilitation, and there's a way to kind of rehabilitate someone's memory and attention, and there's a pretty good evidence base for that. It's a little time consuming, and it requires a kind of a heavy investment by the patients to get to rehab, to do the modalities and exercises that the therapist wants to do, but it's pretty effective. Our patients usually want to get better quicker, so we have other options as well that involve medications. So, you know, when you're thinking about using something to treat someone's cognition, you should make sure that their sleep is regulated first. If they're having trouble with sleep, then all the meds in the world are probably not going to improve their cognition. Anybody who's stayed up at night with a sick kid or knows that their brain just isn't working normally the next day. So we're thinking about medications for cognition and attention only when we've regulated sleep. And often we start with caffeine because that's pretty palatable and acceptable. And patients are surprised that caffeine is a neurostimulant that improves cognition and attention. And so that's where we often start. But we use a lot of these other two drugs. The middle one in particular, amantadine, was developed as an antiviral agent, but it's actually a neurostimulant. And it's used a lot in the TBI world for basically arousal as well as for irritability. So you can think of it as like something between the Starbucks coffee on the right and the Ritalin, Starbucks coffee on the left and the Ritalin on the right. It's a mild neurostimulant. There's a decent evidence base for it. And it's not a controlled substance for athletes that are NCAA athletes. They won't get dinged for using this medicine. It won't show up in their urine. So if that doesn't work, or a patient gets a partial benefit from that and says, I just need a little something more, then we use methylphenidate, which is really effective. And people have a little, you know, I think they raise their eyebrows when we talk about this, but there's a huge evidence base for methylphenidate helping brain injury recovery. Just got to be careful in collegiate populations. Sometimes they like to sell this rather than use it. So you kind of have to just keep an eye on how you're dispensing it. You know, you wouldn't want to give somebody 3 months supply. You want to give them the minimum amount that they need. But we've had patients that were just struggling, and the moment we put them on a neurostimulant, boom, they got better.
Yeah, we had a kid who got hurt in August in football, and we saw him in September, October, November. He hadn't gone to a day of school that entire time. And I went through every headache medicine I could think of, and he kept complaining that it was hard for him to focus and concentrate. I took him off all of his headache medicines. I put him on methylphenidate, and he turned the corner in a week. And he's back in school full-time, doing great. He's now off the methylphenidate. He was probably on it for about 3 months. And he's back in school and doing great now. So it really does, with cognitive exertion, if you have kids that are complaining that they don't have a headache until they go in and they try and study for the test, or they take a test, or they're in a math class, or these really high-level analytical type of classes that really force your brain to think, to work very hard. It provides that support for the brain, and I always say it's kind of like an ACE wrap for your ankle if you had a sprained ankle. It kind of supports your brain a little bit until it recovers fully, so that it's not as hard to think and to process and to concentrate. And most of the time that we've used it, it's taken the headache away.
Almost every concussed athlete with ADD will require a bump in their neurostimulant dose. So it's almost like the concussion has worsened their ADD, and it does temporarily. So just like in our case where we needed to increase his neurostimulant dose, we see that quite frequently. So there are people that don't have ADD who need to be on this temporarily. The people who do have ADD almost always need their neurostimulants temporarily increased. All right, how do we treat vestibular issues? Well, with vestibular rehab, which involves these three modalities. They're funny exercises that involve usually several things at once: head movement, eye movement. Often the patient is walking at the same time. So you're basically retraining the brain through compensatory exercise or through adaptive exercises where you induce a noxious stimulus, something that makes them nauseous or dizzy, and you start at a low level and increase it, until they can tolerate it. Or postural control exercises where like you're standing on a foam ball and someone's throwing something at you, so you have to maintain postural stability and track something through space. So this is really brain retraining, but it works. And it doesn't take much to get the brain back online. The problem is there aren't many physical therapists that know how to do this. So you have to find a physical therapist in your area that knows how to do vestibular rehab. It's not something that is a typical modality for a physical therapist. The problems with convergence and accommodation can be treated with a different type of exercise. It's called vision therapy. And we've had occupational therapists at our university do this, but now our physical therapists are doing this. I think it's pretty straightforward to teach a therapist how to do vision training. And a lot of it is just things like pencil push-ups where you're holding a pencil out at 3 feet and bringing it towards your nose and trying to look at the tip and then moving it back out. It's kind of back and forth, doing these repetitive convergence training or accommodative training exercises. My sense is that it's not difficult. You just need somebody who's been trained and knows how to do it. But it's also fairly effective. There's a couple of visits and you're usually better. Okay, mood disorders. I'm hoping Pam will help me with this. When we kind of come upon someone who's got anxiety or depression, the first thing we want to do is discourage social isolation, which is, you say, well, of course, why would you do that? Well, one of the first things everyone tells a concussed athlete is don't look at your cell phone. And this is how adolescents communicate with each other. So you pull that device away thinking that you're helping their concussion, their headache, it actually really worsens their mood. You cut them off from their peeps, from their homies, from the people that they get a lot of positive reinforcement. So we really try to loosen up on that cell phone restriction thing because it's so much more important for them to stay connected. We want them exercising. We want to make sure that they're sleeping and that they stay optimistic. We do spend a lot of time just trying to keep them optimistic. Mm-hmm. Occasionally we've needed to put people on SSRIs. Occasionally we've needed CBT. We have a group of therapists that work with us. So it's good to have those in your skill set, but if you do the first 4 or 5 things, you probably won't even need to get to that SSRI point.
Yeah, and I think the biggest thing is ask them about school and really understand how stressed and anxious they are about school, because even C students get worried about all the work they're missing, and as we get them back to school, they could be sitting in the classroom but not able to do anything, but they're paying attention to every assignment that they're missing, every reading that they haven't done, and they're tallying up that number in their head, and that's very anxiety producing for most students. They don't want to fail, they don't want to be behind. So always ask about school. There's always one teacher who's an eye roller, it seems, and doesn't believe the student, and that's really, that one teacher can undermine the entire recovery process. So you really want to ask about school. If they're not sleeping, what's keeping them up at night, and go after those and support them in those. Okay,
so return to contact sports. I just want to bring up this issue that the way we decide who goes back to sports, or actually the timing of it, has pretty much entirely to do with symptoms, but also with our physical exam, I suppose. I wrote down symptoms. But what I was trying to point out with this slide is that it's very likely that there are processes in the brain that are still unfolding after the concussion at the time that we're sending kids back to hit their head. So we have presumed that when they're normal to us, physical exams, symptom-wise, that everything's normal in the brain. It's probably not the case. So that's something to keep in mind. If you ever want to err on the side of the timing of return to play, erring on prolonging it would be safe rather than short, because there are processes that probably go on for weeks to months. We don't really know, though, whether someone getting hit at those time points is harmful. So there's a theoretic risk, I guess is what I want to say. And as we have more objective ways to monitor these activities, we may find that our recommendations for when we send someone back to play will change. But this is just something to keep, we don't want to make you anxious about this, but just to be cognizant that there are cellular events that are probably still unfolding even when we're sending people back. So how do we decide when someone can go back to contact sports? So we feel like they have to get over these 3 hurdles. They have to have no symptoms at rest, and they have to be off of whatever headache medication we put them on. So they have to be symptom-free at rest, off the meds, and their cognitive performance needs to be at baseline. So, either the SCAT, however you're testing their attention and memory, need to be at baseline or at least not impaired. And for us, their vestibular function needs to be normal in the office. Because if that ain't normal, they're at risk for getting hurt, right? If they can't maintain postural stability or track an object coming at them, then I don't care what their symptoms are, they're at risk for getting hurt. And then the third thing, they have to be able to get through that graduated return to play protocol without symptoms. So basically no symptoms at rest, and then the last thing is no symptoms as we get them actually exerting themselves. This is the official return to contact sport progression from the latest consensus statement in 2016. It's a 6-step process. Each one of these steps has to be done on a different day, so you can't do more than 1 step on a day. So you could tell your patients when they're asymptomatic at rest, they still got 6 days before they can play in a game. They got to go through this progression. And they have to show that they don't get symptoms with gradually increasing levels of exertion, including a contact practice. So this is kind of written in stone. This is why ED people really can't, emergency folks really can't clear someone for return to play, because they can't really oversee a 6-day return to play program from the emergency department. There also is a return to learn kind of progression that was articulated in the statement, and it's very similar. It's a stepwise kind of progression where you don't throw them in to full days right off the bat. You have them start out with a few hours, and as they're able to tolerate more, you kind of ramp up their activity. Did you want to say anything more about that?
Yeah, the one thing that I find frustrating is when providers make a blanket statement like, you're out of school this entire week. I've had some providers take kids out of school for 2 weeks. And again, recognize that every kid is different, and to take a kid out of school for a week, depending on their age, can be highly anxiety-producing. One, you're taking them away from their social circle. 2, you're taking them away from their academics, and they know what they're missing, and they'll start stressing about that. So I would say, maybe see that kid, the day of diagnosis, follow up with them a couple days later, or at the most a week later, and see if they're ready to go back to school. Some kids will be ready after 2 days. Some kids will need the full 2 weeks, but to just make a blanket statement to keep them out of school for 2 weeks, I think is potentially more harmful than seeing them more frequently and gradually getting them back over that 2 weeks.
Okay, so that kind of would conclude the kind of the prepared statements that we had, and we're very interested to hear your questions. Oh, before I do, so this is just me and Pam, and if you wanted to contact us, there's an email account there that we typically give to patients, but we can answer questions from anybody through that. Anybody in the Rochester region can refer people to us to that phone number, but if you have just questions, you can use that email account. Okay, so what is this now? I read these? Okay, so here are a couple questions that we have. What are the best ways to prevent concussions? Do helmets or mouth guards really help? So helmets don't entirely eliminate them, but the thought is that they probably reduce the severity of concussion. The real problem for the brain is head rotation. Because our head is sitting on a neck, and the head is has a pretty big mass, that when it hits, it swings around on the neck, and that rotation is what's the problem for the brain, because that's that rotation kind of makes the neurons, which are like big wires, it makes them stretch. So really, you have to prevent head rotation to really eliminate concussions. So that helmet absorbs some of the impact, so reduces probably the rotation a bit, but it doesn't eliminate it entirely. Mouth guards don't help.
No, and I would also add that there's emerging research on neck strength as something that would help reduce the incidence of concussion. So, you know, working on kids, so since a concussion is a whiplash injury, which is kind of what Dr. Vazarian was just saying, if you can strengthen the neck, they're showing that the kids with stronger necks tend to have less incidence of concussion. So I would tell my parents, you know, I'd invest in, you know, getting a trainer to work on some neck strength versus some of these helmets that they're coming out with. The other thing that makes me nervous about the helmets is that they're kind of advertised as preventative for concussions, and because a concussion is more of a whiplash injury, some athletes go out thinking that they're kind of immune to the concussion because they're wearing this new lacrosse, you know, the women's lacrosse helmet or whatever, and they have to recognize that, you know, if they go up to head a ball in soccer and they collide with another player, if they hit their head and they have a whiplash type movement, the helmet will help with the impact injury, but probably will not help much with the whiplash type concussion injury. So, but a lot of people are still wearing them, and, you know, I would never tell a parent not to get one if they wanted to get one, but just to not be deceived that this is going to absolutely prevent a concussion.
Yeah, yeah, you got to prevent rotation. And mouth guards don't. So certainly sticking to rules will also help, like in football, not tackling with your head and things like that. Can someone have a concussion even if they didn't hit their head? Yes. So anything that causes rapid deceleration of the head will lead to that head rotation. So someone belted in a car that rapidly decelerates because it hit something, the head snaps forward. Absolutely. Common cause of concussion. One of the things we see in hockey players a lot. High-speed collisions on the ice, shoulder to shoulder. And so there's no head movement at all. Both athletes' heads will rotate because their shoulders have hit. And so you don't need head movement, you just need rapid rotation. Do you recommend baseline testing for athletes in sports that are at higher risk for concussions? If so, do you repeat this testing as the athlete ages? Yes and yes. I like the idea of baseline testing. It's super helpful for us to be able to evaluate someone after an injury. There's so much variation in testing. Repeating it, I think it's every 2 years they're asking for repeat testing, and especially during adolescence. Anything to add to that, Pam?
Nope. I did just learn of a school district around here that pays for the cognitive testing, the computer baseline testing, but does not use it to clear their athletes. Does not retest them to clear their athletes. And I would argue that there's really no reason to baseline test them if you're not going to use it to make sure they get back to their baseline before they go back to play.
Question, do you ever have patients or parents reluctant to keep their child out of sports for the recommended time? How do you address that? This is Pam written all over it.
Yeah, although now with everybody hearing more about concussions, I'm finding it's the opposite way. The parent is more hesitant to allow their kid to go back to sports. But we do have some of those patients, and really I just kind of get into a little bit of the simple pathophysiology of the injury, and I do equate it to an ankle or a knee and say, hey, you know, if your kid broke their ankle, they'd be out for 6 to 8 weeks. I'm asking you for 4, and this is your brain. So let's keep this all in perspective. And then I also say, if they get another concussion, your kid may be out for the rest of their season or for their career. And so what are you willing to risk with your kid? So if you keep it to the facts, you know, the objective facts about what a concussion is and how it impacts their brain and what the recovery is like, we're pretty successful in convincing parents that they need to let their kid recover.
I often doing the exam in front of them so they can see that they're not normal is helpful, or to show them the results of the cognitive testing. Usually if you say, well, what about this? It's hard for them to say, oh, okay.
Yeah. So there's another question. What is the definition and time frame for mental rest after concussion? The reality is obviously your brain does so many different functions. You can't ever have full mental rest. So the old definition was cut them off from screens, keep them in the dark room, all that kind of stuff. What we really try to do now is figure out what triggers the symptoms in the kids. So definitely for the first 24 hours, after a concussion, that next day, probably wouldn't send them to school, let them just rest, kind of get themselves together, see how they are, let them start using their phone, make sure the phone's not causing any symptoms. We do try and stay away from video games. The video games can trigger a lot of those vestibular symptoms, so we try to limit those. But again, every kid is different, so it is hard to define what patient A is going to need for mental rest versus patient B, and how quickly each of those can go back to school. So it's based on their symptoms and what triggers their symptoms, and if they're doing great and their symptoms aren't triggered by school, we get them back to school. We don't make them stay out for any particular set time.
Perfect. Another question, how do you decide who's appropriate for amitriptyline? For example, my son has had 2 concussions, and the second was more severe. He was never offered any medication treatment. We decide pretty much based on the phenotype of their headache. So if they have a headache that's migrainous, that's bothersome, we start them on it. I definitely will start them on it early if there's a family history of migraines. If it feels like it's resolving, if they say, oh yeah, it's migrainous, but it's getting better, not. But more often than not, we put them on amitriptyline.
And I think it's also important to note that we don't typically see them the day of or the day after they have their injury. There's at least, there's an average of a week, yeah. I would say, 6 to 10 days. From the time they have their concussion to the time they see us. And so they've had that headache for that 6 to 10 days. They've tried ibuprofen, they've tried Tylenol, and it's this migrainous headache that they describe. So that's when we say, okay, it's time to put them on.
But I really empathize with the person who sent in this question, because I think that's often the thing, boy, when you nail the headache, everything starts to come back into place. And we try to do that as early as we can.
For vestibular rehab, we typically will do exercise intensity that provokes symptoms. For vestibular in the concussion patient, what are your thoughts on how we should provoke symptoms, both for vestibular as well as aerobic?
How much?
Oh, how much?
Yeah, sorry, I think
how much we should provoke symptoms. I think our PTs provoke symptoms pretty intensely.
That's the point.
Yeah.
That's usually the point. And I feel like I'm not a physical therapist, so I can't really answer this too scientifically, but I know that they want to provoke them. It's like almost like desensitization. You start, lightly, and you gradually push them up. Whoever asks this question, I can maybe hook you up with our physical therapist. They maybe can answer that in a little more detail, but that's my sense as well.
Yeah, and talking to them, we do communicate with our PTs quite a bit. They'll say, they do it by time. So they'll do 3 minutes of a certain exercise and gradually try to increase the time that they can do that. So at their first visit, they may only be able to tolerate 30 seconds of an eye exercise before they get really nauseous and dizzy, and then they'll stop. They don't torture them and make them go to the point where they're going to throw up or anything. They document they lasted 30 seconds, so the next time they'll try to do it for a full minute and keep moving on. And as far as aerobic, we do the Buffalo treadmill test, which most PTs are familiar with. So that's kind of how we start them with aerobic. And they'll just kind of gradually get their heart rate up, 120s, 130s, 140s, and when they're ready to clear, they'll get them up to like the 170s.
Yeah, with that treadmill test, they're looking to see at what heart rate do they get symptoms.
Correct.
And then they have them work at a heart rate 20% below that. They say
number.
That's your target from now on. So.
Yep.
I think we've run out of questions. So I think we'll end it there and thank our presenters so much for a really interesting presentation. Thank you.
Thank you, everyone.